Hello, everyone. I'm Tom Davis, Global Sector Lead for Health and Nutrition for World Vision International, and today is 22nd of March, 2021. This presentation is on interpersonal psychotherapy for groups.
Let's talk a bit about the description of this approach to begin with.
One of the most effective models for reducing depression is interpersonal psychotherapy for groups, or IPT-G, which has been approved by the WHO. My connection with this model is I developed the concept for an IPT-G research project in Uganda and then helped backstop it. And we completed the CRCT study back in October of 2019, along with Food for the Hungry, the organization that led on implementation, Johns Hopkins University and Columbia University. I'll be the senior author on that paper. So with IPT-G, you take the depressed individual, male or female, through 3 months of weekly meetings in groups of about 8 people, led by a trained paid staff member or a community health worker, the IPT-G promoter. This IPT-G promoter is not a psychologist, but often has a little college or a college degree, and they are trained for about 10 days on how to do IPT-G. With IPT-G, you encourage a depressed person to regain control of their mood and functioning. The IPT-G promoter helps his or her groups understand that depression is largely triggered by interpersonal difficulties in 4 different areas: grief, interpersonal disputes or life changes, disputes, role transitions or life changes, and interpersonal deficits, things like social isolation and loneliness. You help people to identify the link between these triggers and how they feel, and to learn ways to deal with these 4 problem areas during group discussion and some coaching.
Let's talk some now about the evidence for this model. Concerning the evidence for the IPT-G model, World Vision has led the way on some of the testing of it. World Vision and researchers from Johns Hopkins School of Public Health and Columbia University Teachers College have been our main partners in this. Lena Verdelli and Paul Bolton did a randomized cluster trial of interpersonal psychotherapy for groups in 2002 that targeted depressed adults in South Uganda. They did a later study using IPT-G for depressed adolescents in refugee camps in North Uganda with World Vision, many of whom have been child soldiers. And in the RCT in Uganda, after the 4-month intervention, depression dropped from 86% to 7% in the intervention group, which is a 92% relative reduction. It dropped less in the control group, but some depression does resolve on its own over time without intervention. The researchers also saw significant improvements in functionality and household tasks as well, things like being able to cook and care for one's children. And a separate sustainability study was done 6 months afterwards that found that those results were maintained. IPT-G may also help to address adolescent suicide in lower middle income countries, which was found recently to be much higher than we originally thought. A Lancet report in April of 2019 found that 17% of adolescents in LMICs, almost 1 in 5, reported making a suicide attempt during the past 12 months. It's very concerning. Here's what the depression scores look like in that southern Uganda trial at baseline after the 3-month treatment and at 6 months. It was highly sustainable. But what is particularly interesting to us as an organization is its effect on behavior change, a child's education, and a person's ability to do farm work and to provide for their family. It's hard to believe that someone can be just as productive on a farm or in raising healthy, well-nourished children when they say, I feel down, depressed, and hopeless, or I feel tired or have little energy, or I have thoughts that I would be better off dead, or about hurting myself in some way. These are all statements that people often say yes to when they are depressed. Think of the impact on that across sectors. And indeed, in an IPT-G study in 2016, the researchers asked families who had been treated using IPT-G what changed for them, their families, their children, and their whole community because of the IPT-G groups. And these were both men and women caregivers. And the main things that they mentioned were all things that are important to us in World Vision. Improve school attendance for children, so education changes. Improve productivity, livelihood changes. Improve sanitation in communities, wash changes. Greater cohesion among community members, and reduce conflict in families. So child protection changes as well. What was missing from these earlier studies about depression was to connect the dots. We know that depression can affect behavior change and hurt child growth. We know that IPT-G can rapidly reduce depression in developing countries. What we have not demonstrated is that this intervention to reduce depression, IPT-G, will improve behavior change and improve child growth. World Vision, through my participation, and Food for the Hungry, tested this hypothesis in that project using IPT-G and care groups in Kitgum, Uganda, from 2016 to 2019. And that study was led by Food for the Hungry, but in collaboration with World Vision, Johns Hopkins, and Columbia Universities.
In that study in Kitgum, once again, we found that the depressed women who were treated with IPT-G had a greater reduction of depression than those in the comparison arm, which confirmed our first hypothesis. IPT-G works to reduce depression. However, this difference attenuated after depressed women were reached in care groups twice a month for about 15 months, to the point where the difference was no longer statistically significant. Surprisingly, women who only received the care group behavior change intervention had a decrease in depression of 95% by 21 months post-baseline. The researchers on our team agreed that this may represent a strong therapeutic effect of the behavior change intervention itself, the care groups, and it may be due in part to the behavioral activation and increased social support, which are inherent in that model. We also looked at functional impairment, where mothers were asked, how difficult have these problems made it for you to do your work, take care of things at home, or get along with others? And we saw an improvement, that is a decrease in that indicator, after IPT-G treatment, the midterm, among the women who were no longer depressed, and it remained lower by inline.
This analysis also confirmed our second hypothesis as well. Women who received IPT-G treatment had significantly higher adoption of 1/3, that is 4 of the 12 health, nutrition, and wash behaviors that we promoted. Those are the circled ones here. After treatment for IPT-G, before we even promoted behaviors, mothers were more likely to endorse giving the child iron-rich foods. They said they were washing their hands with soap, including having a presence of a hand washing station in the home. They were properly disposing of child feces, and they were using family planning in greater numbers than the depressed women who did not receive the treatment. The endorsement for these behaviors was about 23 to 32 points better relatively, or percentage better relatively, or about 7 to 13 percentage points. These are preliminary results. They haven't been published yet, so they could be changed, but this is what we're seeing so far. And you should remember this slide from the intro presentation that I did earlier, which shows the behavior endorsement of women who were no longer depressed after the IPT-G treatment, the green bars, versus the red bars for the women who were still depressed after treatment. You'll note you don't see any red bars because they're all 0%. This was very striking to us, realizing that for all of these that we could assess, 10 of the 12, women who were still depressed even after treatment, and those who were never received the treatment and were depressed, didn't endorse any of these behaviors, where you had much better adoption of those who were no longer depressed.
Everyone, I'm Abhay Roke, Interpersonal Psychotherapy.
So let's talk about the extent of rollout and the cadres and different types of community health workers implementing IPT-G. In Uganda, we have IPT-G programs that were developed and implemented, particularly amongst people impacted by HIV/AIDS, but also up in the north amongst women who were just depressed and caregivers of young children. IPT-G promoters are used who have completed secondary school, and some often have some college but not college degrees. But it's been mixed in terms of like who actually implements it. It's never psychologists, but sometimes it's even people like community facilitators. So in terms of cadres, IPT-G has been rolled out by IPT-G promoters, community facilitators, such as in Ethiopia and the Democratic Republic of Congo, child protection staff, that was done in Myanmar, and even through Christian pastors and leaders in Haiti, even though that has not been evaluated yet fully to know how that helped, and volunteer facilitators in Ethiopia. Also in Ethiopia, the SPEAR Food Security Program has community health and IPT-G facilitators in most of 94 Kabiles, and plans to also use Problem Management Plus in half of these Kabiles, training both CHFs and volunteer facilitators. Problem Management Plus would then be used in all of their visa groups in year 2 of SPEAR 2, so they're doing a pretty big test of it there. IPT-G has also been used by World Vision in Kenya, DRC, South Sudan, Haiti, and Myanmar. And in DRC and Myanmar, World Vision targets children above 13 years of age. And in Haiti, IPT-G groups were formed amongst those who acquired a disability due to the earthquake. And a Christian spiritual nurture component was incorporated into IPT-G there. This included training of pastors and Christian leaders as IPT-G facilitators. In terms of some successes we've seen, apart from evidence we've seen of this model, the IPT-G program in Haiti, where a high number of people were disabled by the 2010 earthquake and displayed lots of symptoms of depression. And in one of the camps, World Vision formed IPT-G groups, especially targeting those who had acquired a disability. So this is one thing that we can use with people who are disabled, especially when we see higher rates of depression amongst them. The World Vision Haiti earthquake response also piloted the incorporation of a Christian spiritual nurture component into IPT, as I mentioned. As part of group therapy, participants' spiritual needs were also addressed in IPT-G sessions, and findings about whether or not this resulted in further reduction of depression symptoms compared to IPT-G groups that did not have that focused spiritual nurture is yet to be analyzed, but it's a very promising practice at this point. Given the success of World Vision's earlier IPT-G pilot project in Uganda, IPT-G has also been rolled out in numerous other African countries, including Kenya, Democratic Republic of Congo, Malawi, Zambia, South Africa, and Lesotho, bringing equally positive results. So some of these countries, it's been done by other INGOs based on World Vision's earlier work. So we're kind of the main INGO that I know of working with IPT-G, and we're partly responsible for the fact that it has spread in many countries in the world. World Vision is also supporting rollout of MHGAP, the MHGAP intervention guide and program in the post-conflict area regions of northern Uganda. MHGAP focuses on capacity building of primary healthcare workers and systems, and the project also integrates IPT-G and supporting user groups of the services to be actively engaged in advocacy for the needs of people with mental, neurological, and substance use disorders, or MNS disorders.
There are some challenges, of course, with scaling up and using IPT-G, and those include a lack of mental health staffing to provide the necessary training and clinical supervision for these community facilitators. We often need to bring in consultants for training and also do some training of clinical staff if they have no formation at all in mental health and psychosocial services. Also, dealing with suicidality can be an issue for people who say they have thoughts that they would be better off dead or thoughts of hurting themselves in some way. And have a plan for ending their life. You need to get a mental health professional to see them right away. With COVID-19, it's actually now allowable to do that consult over the phone, so that's a positive move. Also, ensuring sustainability of IPT-G services after projects end. So sustainability of services, not the results, can be a challenge. The groups often keep going, but not the support to these groups. 6-month follow-up studies have showed that depressed people remain low, that depression remains low among the group members, so that's positive. Post-IPT-G, a follow-up mechanism is necessary to ensure children's and caregivers' mental health needs continue to be addressed and they're not neglected once engagement ends. Comorbidity can be a problem where depressed people also have other psychological problems that are not addressed as well with IPT-G, like anxiety and schizophrenia. And of course, some clients will fall back into depression and experience a relapse regardless. And also during disease outbreaks like COVID-19 and Ebola, implementation of group activities are not always possible, which can make it hard to implement IPT-G since this intervention requires face-to-face interaction. Thank you very much.